Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Today we have a really special guest. I've been looking forward to this for quite a while. Dr. Maya Goldenberg. No relation as far as we can tell. Dr. Goldenberg has been focused on evidence-based medicine, vaccine hesitancy, but from a philosophy of science perspective. So she's a philosopher, and we haven't had anyone on the podcast yet who isn't a medical researcher from the medical side of things. And I think the more we look into this, the more I feel like this isn't really an evidence question. These are philosophy questions. These are how do we know what we know questions. These are values questions and communication questions. And these are all things I really hope we can get in on today, and in particular, talk about her relatively new book, Vaccine Hesitancy, which is amazing, which we'll talk about in a second. So anyway, welcome, Maya, to the podcast. We really appreciate you coming on board.
Thanks. It's nice to be here.
Awesome. So Maya, you have published a book, talk about perfect timing, 1 year into the pandemic on vaccine hesitancy, and had enough time to write a preface to sort of steer it in the right direction too, with all this research from the previous 5 years. So perfect timing. Tell us a little bit about it, if you will, and then I'd love to just jump into all the questions I'm sure we have and get into the fun conversations.
Okay, so you're right that it was maybe the best timed philosophy book ever. I'd been doing this research prior to COVID. And when I was working on it, the big questions around vaccine hesitancy pertained to childhood vaccination. So parents who didn't want to vaccinate their kids. And this was certainly a familiar topic. I was also, a mother of young children. So I was, it was part of my world that I would meet people that were ambivalent about vaccines. Mm-hmm. So I started looking into it. I should say that I started out with a research question that was something along the lines of, what's it going to take to convince these people to get vaccinated? I mean, we were talking about pediatric vaccines, which, unlike COVID vaccines, have a long track record. We have good long-term data to suggest that they are very safe and very effective. So I started looking into that, but it was actually my readings mainly in science communications literature, because there wasn't much philosophy. Mm-hmm. There was actually hardly any philosophy on this topic. So reading into that literature, I started to realize that was the wrong question. Everyone kind of assumed there was some missing knowledge. Yeah. That was once people had it, then they would see the vaccine issues the way that the experts did. And there's so many assumptions that go into that end up being wrong. Mm-hmm. So in the end, it's not an evidence problem. In fact, most people know what the scientific consensus is on childhood vaccination. Instead, there was something else going that was inhibiting some people, not everyone, but some people from accepting the expert claims to be justified and something that they should act on. So it was more, as you called it, a communications problem, but the inability to see that, the fact that vaccine communications offered by health services and agencies still kind of work within that framework, which is called the deficit model, the assumption that people are just missing information if you fill that knowledge gap, then they get it. The fact that people still work within that framework suggests that it's hard to see otherwise. It's hard to imagine that there could be something going on. So that's where a philosopher is actually useful, to ask if we're asking the right questions, and look at what are the assumptions that go into how we are framing the debate. So that's where I came into the vaccine hesitancy issue.
And I think that that's really fascinating too, because from a clinical standpoint, working with some of my mental health colleagues who do a lot of like motivational interviewing during their counseling sessions and whatnot, I was having a conversation actually not too long ago about essentially, smoking cessation for some patients. And the person I was having a conversation with was essentially saying the same thing of like, no, more information isn't going to help the patient make that decision. You kind of have to understand why are they, from a behavioral standpoint, why are they doing that, and try to help motivate them to change. But just providing more information isn't going to necessarily provide that change, because for a lot of them, they already know that in this specific example of smoking, they already know that the behavior is not healthy for them. They know the effects and risks of smoking. So you have to approach it from a different standpoint, telling them, oh, you're at higher risk for cardiovascular disease or cancer or XYZ is not going to make them change. If anything, it may actually make them more resistant to want to change.
That makes a lot of sense to me, because telling people that they're not doing well or not doing the right thing is often not motivating. There's also literature on using fear as a technique. You could get cancer, you could die. Also, can cause a kind of resistance and break down the clinician patient relationship.
I want to ask you something about like some of the whys there. I mean, I was really struck in your book and what you just said as well when you started with, oh, we just have to figure out how to convince these people of XYZ, right? And it's this very, we know the right way. There's something wrong with them, whether it's an education deficit, or they're just stupid, or it's religious differences or something like that. There's clearly something wrong with them that they don't see the truth, right? And we just have to find the right key to use to get them to agree with us. And you kind of turn that on its head in your book. And I guess one question I have is, I've seen you write about feminist theory, and I don't know enough about philosophy. Is the way you flip that? Is that related? Is that feminist theory? Is that coming from feminist theory at all, or is that an unrelated issue?
I mean, it comes in part. A lot of my methods come from feminist philosophy of science, which does a lot more listening to what people have to say, and theorizing from the term for it is theorizing from the margins. So you will, instead of assuming that you position yourself, and I presumably have some kind of expertise and even privilege vis-a-vis the issues that I address as a feminist philosopher, just because I am a university professor, so that means things have gone well for me in a lot of ways. But if you are, let's say, talking about something that a behavior or a phenomenon that impacts other people, the first thing you want to do is try to look at it from the perspective of those most affected. So I didn't start. So it was wrong for me to start with this point that there's something wrong with them.
Right.
What you want to do is find out what motivates this kind of behavior. Why are seemingly well-intended, loving parents unsure that they should vaccinate their children in the face of strong medical advice telling them that it's the right thing to do.
Yeah. And, I think in the introduction to your book, you were talking, there was a critique of your book that you had shared. And one of the critiques was, well, you didn't spend enough time debunking some of the fraud that's out there, like around Wakefield and things like that. And, I thought your response, if I understood it correctly, along the lines of, well, what I'm really more interested in is, why are these mamas, gravitating to that? Why are they asking these questions, as opposed to, well, if only they knew that he was a fraud, everything would change, type of thing? And I just thought that was a really very different way of looking at the problem. And clearly the way we're looking at it now is not working anyway.
Yeah, and it's only gotten that motivation. So now we've got this burgeoning field of misinformation studies, which is making what I just described like even more necessary. So anybody who disagrees with certain positions on public health, certainly around COVID, is a misinformant. They're
Mm-hmm.
just spreading misinformation or
Mm-hmm.
disinformation, and of course, there is misinformation out there. There are
Mm-hmm.
people that are coming up with wild ideas that are meant to harm rather than help. But the idea that, let's say, our experts or our science communicators are the guardians of truth, and
Mm,
everyone else is a misinformant is not a productive way to have these complicated discussions.
I like that. There's something philosophically right about that that feels right in my soul when you say that. And then there's also something very pragmatic about that as well, which is like, well, that's not going to work, and it hasn't worked anyway.
Yeah.
Adam, I'm curious. So Adam is in clinic much more than I am. I see patients 1 day a week. Adam is sort of in the trenches all the time. Adam, I'm curious. Like, how does this play a role? These conversations play a role in your day-to-day experience, especially around COVID. I'd love to begin to shift this, if possible, towards COVID because that's the most obvious connection there. Although I love there's actually a nice spectrum, right? We've got the parenthood, childhood diseases, which the book was originally on. Your example, Adam, of something where there's a known harm that no one would even debate that harm, yet they still do this action, as opposed to different evidence or believing different evidence. And then there's COVID, which is we have zero to no evidence, at least at the beginning, and we still have to make public health decisions, apparently with certainty, makes me very uncomfortable as an evidence-based provider. So anyway, Adam, how does this all play out in clinic? What's been your experience?
Yeah, I mean, honestly, my experience has kind of evolved from that of being sort of like just giving them more information of like, no, this is why you should vaccinate. These are the harms of not doing it. Should you choose to forego it? Um, I was never one who, dismissed a patient of like, hey, get out of my clinic if you're not going to vaccinate. Because I think that leads to more harms. Because then if you lose patient care altogether, well, then you're just not going to be able to address any medical conditions.
Mm-hmm.
And if you can get them following up on a routine basis and develop that trust with them, then perhaps one day they'll be more receptive to considering at least maybe one vaccine. And I'd rather have a patient get one than none. Um, and so it's kind of evolved over time, and just looking at the literature, especially when I was like a first year resident, when I was like really looking into the evidence behind this, there's really nothing there that's showing anything to help promote uptake of vaccines other than just really developing a strong patient clinician relationship, which seems to be the ultimate driver. Like they've done, okay, what if we send text messages to patients? What if we give them videos showing them, like talking to them about the safety? And what if we do all these other things? And like nothing is working except for having that relationship with patients and building that trust with them. And so really what I'm doing now is really just trying to build that trust with them. And if they're being resistant, not pushing back too much, but just saying, hey, here's why we do it, kind of giving them just some of the baseline information of here's why we vaccinate for hepatitis B. Even if you are at low risk, here's why I would still recommend it, because accidents happen, you never know. Here's in just kind of like here's what we're seeing from the data when it comes to the safety. So I am giving them the information, but also not forcing it onto them, and just trying to have that relationship with them, and at every visit just kind of checking in and seeing if they're ready for it. So you know that's really my approach. It's nothing too complicated. It's just making sure that I'm having that patient rapport with them, and just making that I'm making the strong recommendation to get them, and then kind of going from there. Yeah.
That resonates with what I know and what I know about the literature on changing behavior.
Hmm.
So there's a lot of behavioral psychology research into all kinds of interventions. What if we use this language? What if we send
Hmm.
a text message? Um, what if we use a red font? Those
Hmm.
kinds of things. And none of them work. None of them have created a statistically significant change. At best, there can be short term change in people's understanding of the issue when you give them new information. but that doesn't translate into behavioral change.
Hmm. Hmm.
So this is okay. So I think Adam is like putting his finger on something that you talk about in the book, which is trust, right? Like, so what's the issue? The issue is trust, and people want to follow people that they trust or listen to people that they trust. And so I guess the question for both of you is, how do you do that? Like, how do you build that trust? And if we're talking about a doctor-patient relationship, and one of the things you mentioned a lot is this concern for big pharma and undue influence and conflict of influence, and if the physician, because I'm thinking a lot about check marks and quality metrics in EMRs about, your outcome is not whether the patient felt heard or whether you understood the patient's needs. It's, did they get vaccinated in this visit or not? Or did you talk to them with a red line pen with a handout and a text about this, right? So how do we, as providers, build that trust, especially where we may be seen as part of the system that we don't, maybe doesn't deserve that trust, or maybe it does, but they don't have the trust?
I mean, I think that's the $1 million question, right? It's hard. You can talk about building trust, and your metrics do matter, unfortunately, and it's just a tricky thing to navigate. And I try to let patients know, hey, I got vaccinated, I did great with it. If you were my brother, my sister, my mom, dad, uncle, whoever, if you had these same conditions and you were someone close to me, I would say, hey, like, you should get this vaccine because of these reasons. Sometimes that works, sometimes it doesn't. And if it doesn't work, I don't keep pushing back or yell at them or anything. I just say, okay, well, if you have any questions, like, just let me know. I'm more than happy to talk to you about them. And then I kind of just move on with the visit. And then when I see them for follow up, I just do a check in and say, hey, I know we talked about this last time. I know you said no, but it's just my job to make sure that you're safe, and just want to see if you're ready for these again. Some patients are just not going to do it, and it's just the unfortunate part of medicine. But I still don't think you should kick someone out of a practice for that, because then the worst thing that can happen is you lose patient care altogether, and then they're just not getting care.
Um, there's so much good content in what you just said there, Adam. So one is it's actually the concept, a philosophical concept, which is epistemic trust, and it's gravitated into psychology research too. Um, this idea about like when this idea that you trust people as an information provider, and there is of course a component of that relies on your credentials. So, are you in a position to give me advice about vaccines? As a clinician, I'd say you probably are. But there's also a component, there's a moral component. Like, people will trust people if they think you are in a position that you will know or can know, but they also need to have some kind of sense that you are acting in their interests. So building those relationships is where that happens. The fact that you ask about them, express concern, personalize it, and also don't turn away from them when they say, I'm not ready to vaccinate, or maybe refuse vaccination altogether. Those are important parts of your interpersonal relationship. And the provision of information will be more accepted if they trust you as a good person, as someone that is actually working in their interests and has their interests at heart. It's not separable, and that's why it's kind of known that a lot of people don't trust, let's say, big pharma or the chief medical officer, but they're more likely to trust their personal physician because they have that face-to-face relationship with them.
And Maya, are you seeing if there's any sort of issues of this being like an international problem, or is this really just an issue that we're having in the States? Like, are other, um, perhaps like less socioeconomically advantaged societies or countries also experiencing lower rates of vaccination uptake, or any sort of concerns around obtaining vaccines, or are they way more receptive to it? And this is just more of like a problem of privilege, where in the States we're privileged not to have to deal with poor sewage in most areas, and so things like hepatitis B and hepatitis A are not rampant here. um, whereas they may be in other parts of the country, or like, polio is essentially non-existent in the States, but in other countries, it's still a thing.
The best correlate for vaccine uptake is actually trust in government. So, insofar as people trust this, I should say the system more broadly, maybe not government. Insofar as people trust the system, they're more likely to take the vaccines that are being recommended to them. So you can imagine how living under very extreme, living in extreme poverty, living under extreme circumstances might motivate you to want to get the vaccines. But if you don't trust the government to provide them safely, you still might refuse it. And that's seen in countries too, where there are, often the kind of concerns about vaccines reflect the cultural anxieties of the place and moment. So, there are countries that have come out of civil war where they think vaccines are being used as a genocide, as a weapon of genocide, right? That's not, you don't see that in high income countries where it's usually, right now the concerns about vaccines are about government overreach and big tech, taking over our lives. So it's very reflective of the concerns at that moment and place.
And is there any evidence showing improved uptake or resistance depending on the amount of vaccines that are being administered during a visit? Because sometimes I'll run into a problem of saying, hey, you're due for all these vaccines, and like, we can get them all done today since you're here. Then sometimes some will say, like, yeah, let's just get them all done. We're here. Let's just get it over with. Other times there's, people would rather have like one every couple of weeks, or, at one a month or something like that. And usually when it comes to that, I say, hey, we've done the studies to show that if you actually administer multiple vaccines at the same time, at the same visit, not only is it safe, but you may actually get an improved immune response to that, rather than sort of isolating them out. And so sometimes I get buy-in with that. Other times people are just like, nope, I just want the one, and that's it. Have you seen if there's also sort of like a quantity of vaccine administrations per visit that's influencing uptake?
Well, that was a common concern. It was kind of the middle ground for parents trying to work through their vaccine concerns and anxieties, where, some say all the vaccines, I'll just follow the recommended schedule, that's fine. Some people say no vaccines. Other people wanted we can call them alternative schedules, which could be spread it out, because there are some ideas that they seem to resonate with a lot of parents, that maybe we just administer too many too quickly. Of course, there's no scientific evidence to justify that claim, but it somehow speaks to nervous parents who don't want to say no to everything, but they want to be that sort of in that reasonable middle, and slowing it down, spreading it out makes sense to a lot of people. My suggestion is what you said was right. There's no scientific evidence to suggest that doing them all together is harmful. We also lose. It's known that you lose a lot of parents along the way if you schedule multiple appointments. But at the same time, if that's what's going to get parents to vaccinate their kids, why not do that? Maybe they really are committed to coming back to you for multiple visits. There was a moment when, I remember earlier when I started this research, where there was kind of height, I think it was after the Disneyland measles outbreak, there was kind of peak frustration with parents who refused vaccination for their children. And there was this tendency to sort of broad brush everyone as an anti-vaxxer. So even the request for a spread out or modified schedule was seen as equally bad as not vaccinating at all. And I thought, that's a missed opportunity. Why not engage parents with some kind of alternative scheduling? Yes, it's complicated. Yes, all those things, but isn't it somewhere that you're if you don't meet them halfway, in fact, they might say, why wouldn't you let me do this reasonable strategy? They might even be suspicious why you won't let them do that.
I want to ask a question about that, and maybe turn it towards the COVID pandemic too, because I think it's somewhat related. And you bring this up in your book too, which is the benefits for the whole versus the individual choice and decision making. And so For example, if we're thinking that, if we do it all at once, there's more likely that society will be vaccinated versus lost to follow-up attrition. But on an individual level, a mom is looking at you and is like, well, why wouldn't you let me do this? I got this Sears book. Why wouldn't you let me do this? I still want to do it, but I want to think about each one. Like, how could you really say no to that, right? And in your head, it's like, well, if I did this to 1,000 people, society's not protected, right? And so you have to balance these societal benefits versus individual choice and ethical issues. Again, bringing it back to philosophy. And this is my obsession lately with COVID and vaccines, which is, how do you make that ethical choice philosophically, as a society, as an individual, as a doctor? How do you strike that balance? I mean, in your book, you talk about things like, minimally invasive options, depending on the information, the urgency of the situation. But how do you do that? And I'll tell you one last thing, maybe you can throw in your discussion about this, because this just drives me crazy. It seems like, from a pragmatic perspective, if you're going to make a public health announcement for society, you have to be black and white. This is the truth. This is what you need to do. That seems intuitively right, to get the most people to agree to what you want to have happen and protect society. As an evidence-based researcher, it's like, that is not how science works at all. And that is not how evidence works at all. And there's, lag time bias, and it goes up and down. It's going to take 20 years until we can meta-analyze this properly anyway with the right precision. So how do you balance that too, as far as those conversations with the public, especially with an emerging disease that we don't know much about?
I mean, there's always going to be scientific uncertainty. We can't get around that. I understand why public-facing researchers and public health people don't want to admit to all the uncertainty that's out there. But look what happens when we don't. There is this drive to overstate the certainty about it. And the publics are not stupid. They know that there are adverse events that come from there are harms and there are risks associated with any medical intervention. So when you keep hearing the message, they're safe, don't worry about it, pretty much parents used to hear pretty much, shut up with your vaccine concerns. It comes across as disingenuous. There has to be more room for dialogue. Most people can be convinced. They want their questions to be answered, and to be answered competently. Some people will not be able to. That's what we have vaccine exemptions for, because you will not be able to convince everyone, and that is okay. You don't need 100% coverage.
Yeah, I don't know. I think it's a tough question, and there's an analogous thing, and Adam's going to be like, Josh, shut up about this already. But so I've lately become interested in forensics, in law and medicine. And when I went into it, I think I'm going through my own crisis of faith that is analogous to what you've described the research literature going through in your book, which is, at first I was like, why are malpractice decisions, why are medical liability decisions, which are purely technical in nature, and we're literally doing mathematical equations to come up with causality assumptions and all this. Why are we leaving this in the hands of a jury, right? Why are we letting people with zero medical background or scientific background make these decisions? And I was furious, and I was like, I don't understand this. This is crazy. We would never do this in medicine. And even the experts that come up, like, they're not even following evidence-based medicine. I have all these problems with the field of forensics. And then the more I learn about law and law theory, and maybe even the philosophy of law, at least in an adversarial system like we have, there's an incredible ability of everyday folks to figure out the truth and to ferret out trustiness from different experts, right? And so you have this litany of experts that will present this information to a jury of your peers, the jury to the publics, as you say, and they have this remarkable ability to know who to trust. And it goes on subtle cues. Like when they do research on this, it's not the information that's presented, it's subtle cues about the person. So I wonder, am I just stretching for that association, or does that make sense as well? Is that related?
It is related. There is a whole literature, so philosophical literature and support of social science too, about how people come to know things. Mm-hmm. And it is largely driven by trusting the right informants. And when we ask, let's say, for expert advice, we can't really assess the pronouncements that experts make. If we could, we probably wouldn't need their expert advice. So we are looking for those heuristics that you're referring to. You know, what do I know about this person? What can I take from this person? And sometimes we're wrong about it. Like all of us have all kinds of implicit biases that make us trust, you know, certain people because of how they look, and they might not be trustworthy at all. But the point is, we're doing it all the time. Like, we're actually quite sophisticated in our decision making because we bring in all those cues, and sometimes we do it well, and of course sometimes we get it wrong. But trust is complicated that way, and it is our way that we navigate new territory. It's, you know, actually how we get through the world, because there's too much knowledge that we need in order to just live our lives day to day. Like, if we said, okay, I'm not going to trust anyone, I'm just going to research for myself, like, I wouldn't be able to do very much.
Yeah. Like I've heard people say, well, you don't question how planes work, you just get in a plane. You don't question how cars work, you just get in the car. And that resonates with me. And so it all comes down to these heuristics. And then I wonder if we've gone, you know, with the evidence-based medicine movement, it's all about understanding cognitive biases and how heuristics break down. And so maybe we've just shifted too far in the other direction, and it's somewhere in the middle where you need solid evidence that needs to be communicated properly, but you also, at a certain level, need to be able to trust your own heuristics too, maybe even just with some awareness of the common cognitive biases or something.
That sounds right to me.
Okay, cool. Well, Adam, any last minute questions or comments?
Where do you see, I guess, sort of the next 5, 10, maybe 15, 20 years of this issue moving towards with regards to vaccine hesitancy, and how policy is going to change, or how, you know, is there any sort of indication in the literature where things are moving towards to help increase the uptake of vaccinations?
I think there'll be lots of reflecting on what happened during our COVID years. I'd say it did not go very well. So we had, of course, the hardest situation, an emergency that we had to deal with quickly, a new vaccine. So of course it didn't have all the long-term data, and I would say impatient for the countries that were lucky enough to have the vaccines widely available. There was impatience to get it into people's arms. So there was, I'd say, in the early stages, there was some good outreach efforts, persuasion, really, to try to convince people, especially convince people that vaccinating was a good idea. But, you know, persuasion, I don't mean to sound nefarious. It's helping people make informed decisions. It doesn't go as quickly as I guess people would want it to, because you have to build the trust. You have to break down all kinds of barriers, socially, emotionally, all kinds of things like that. There was a quick turn to mandates in a way that I think was detrimental in the end. When vaccination wasn't fully embraced by the publics at a fast enough rate. That was certainly the case in the US, but other places too. Suddenly there were workplace mandates, public access mandates, education, access to education mandates. And look, there are justifications for vaccine mandates. I'm not speaking out against them. I disagree with the many critics who think that vaccine mandates are always unjustified and that there's no historical precedent. There is, and there is even ethical precedence for them too. Mandates are certainly justified if they are protecting people from getting COVID, but these our vaccines were not that kind of vaccine. You could still get COVID, and it was keeping people from mobility, from education, from all kinds of things that are actually important liberties. So the mandates kind of outstrip that ethical and legal requirement, in my opinion at least, that it is the least invasive possibility. It didn't seem like that was done, and there was harms because of it. Whereas there were people that were perhaps okay with vaccines and not okay with vaccine mandates, suddenly tied those two together, and it made the vaccine itself more suspect.
Yeah, and I think part of the thing too there, and I know we're running up on time, was that if you were to talk to someone who's a critical care provider, they would probably have the opposite view of like, listen, we have no beds, everyone is on a ventilator, we're taking beds and rooms away from other units
Mhm.
to help with COVID, and if we have something that perhaps it's not preventing you from getting COVID, but it's preventing you from needing critical care and being put on a ventilator, then it's something that we should instill. And that was kind of where sort of I was of like, hey, we have no beds, it's already an overburdened system. If we can prevent someone from having a significant harms from this, and then the economic component of that, of like, now you're admitted to ICU for a long period of time getting all these treatments and you're going to get a big bill. Like, there's more to it than just preventing or contracting a disease. There's other components to it of like, okay, are you missing work? Are other family members now going to be affected? Is society going to be affected from indirect healthcare costs, right? Of not being able to work, et cetera, et cetera.
Keeping the hospitals afloat was definitely the best reason to get vaccinated, but that gets lost when you start turning it into a political issue about whether you vaccinate or not. But and also there's other questions around that about why are our hospitals overburdened? Why is healthcare chronically underfunded? I mean, we can get into a big priorities debate rather than just talk about vaccines there.
Thank you so much for joining us. The book is fantastic. I don't know how you got that, what you did in another life with that to get that kind of karma. Like, the timing is just perfect. And hopefully it got into people's hands at the right time when they were trying to understand this. The book's absolutely fascinating, people. I'm still working through it. It goes through things that I'm obsessed with, like scientism and science communication, and really how philosophy plays into this role. So, and it's a wonderful read too, very well written, very clearly written too. And I wouldn't say it's certainly not written for a philosopher. I don't think it would be written. It's open. It's accessible for the general public. Wouldn't you say?
That's what I tried to do.
Yeah. That came across to me. You don't have to have a medical background, or certainly not a philosophical background. So, Maya, thank you so much for your time today. Maybe we can twist your arm to come on again, because I just feel like we could talk about some of these aspects. So much of what we talk about on this podcast comes down to philosophy. That's the thing. Philosophy and values, right? Like that's what it comes, and values are probably philosophy. So like at the end of the day, how much of this is really evidence and how much of this is philosophy? So hopefully we can have you back on sometime soon.
Sure, I'd love to come back. Thanks so much.
Okay, thank you. Take care.
Thank you for listening to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.